the good news is that only the brave and very interested doctors are staying until the end. And for the rest, it was not worth anyway. So it's your privilege to get educated at the end of the day. The idea of customized cross-linking came up 4 years ago, 5 years ago, when B.J. Dubs from Cleveland, Ohio, at a conference told us that, hey, keratoconus is not a disease of the eye. Keratoconus is only a localized weakening of the cornea. Do not always talk about genetics and all the stuff. It's just a localized weakening. And at that time, you know, if a theoretical guy comes in and tells you stories about things that you have learned for 50 years ago, you don't believe it right away. And the experimental guys and PhDs, they always know better anyway. So, but then he came up and said, hey, I'm taking a normal cornea, doing a finite element modeling, which is a very sophisticated way to do that, and I'm weakening the cornea elastic modulus by 10%, he couldn't see anything. And then he weakened it by 30%, and then on a sudden a kind of keratoconus started. And at the weakening of 45%, so the stiffness of the cornea was weakened by a factor of 2 nearly, then on a sudden a keratoconus started. And that's when I thought maybe we should follow that approach and just looking at our corneas, and maybe we should do the cross-linking only in that area that is weak and leave the rest alone. But now the question was the next thing, hey, what is the weakest area of the cornea? Is it here? Or is it at the thinnest point? So that maximal K, is that the thinnest point? Or is it somewhere here at the bulge, at the posterior, maximum posterior float, where the cornea is bulging forward? Hey, that was a tough question. Who is for K max? I was at the beginning for K max, and the English guys in Moorfields and King's College are still believing that this is the right thing. The thinnest point, maybe, that's weak, and the bulging forward might be also. The problem is, why isn't it coincident? Why isn't the thinnest point exactly that where it bulges forward? Now the reason is clear. It's the epithelium that modulates the corneal shape over the peak. Today we have higher resolution OCT. The MS38 measures it to 3 microns precision, and you could see over the cone you have 28 microns thickness, and here it's 58 or 78 microns thick. So that shape is already modulated. You would have to remove the epithelium to get the real shape. Thickness is the same thing. You're measuring from epithelial surface down to endothelium, so you make the same mistake again. And the only area where you don't make the epithelium mistake, modulation is saying, is at the posterior surface, because the endothelium is a one-cell layer, cannot modify the thickness or the bulging forward, and that's why I believe that is the right way to go. We proved this in Dr. Koller's eye. He is a young man who got 15 years ago in one eye. He came to us and asked for LASIK. So I looked at the corneal topography and see one eye had a form frust keratoconus, and the other was totally healthy. So I did a LASIK in the totally healthy eye and did a PRK in the other one. And guess what? 3 months later, he had a keratosis in the LASIK eye, and the other one was the good one. But this is now the LASIK eye. Now, that is the left one is the LASIK eye. That's correct. Now here the K max is far away. The thinnest point is in the center, and this is the bulging, that is the posterior float. Now, since we do have that cooperation with Yale and with Harvard Medical School Development Laboratories, we got the Brion measurement machine to Zurich for 3 months. And Brion spectroscopy measures the elasticity or the stiffness of the cornea optically without touching it. Here it is. Stiff cornea, very soft cornea, and it's very clear. It's not here, it's not there. The weakest point is over the posterior float. And that's something we have to have in mind. It's the posterior float that tells us where the cornea is weakest. And that's how we started then. That is one of the lady, that was a young man with an early keratoconus, and we started then to do 3 concentric rings, having 10 joules in the center, 7.2 joules here, and 5.4 joules, which is the normal dosage, outside. With a radius 9 milliwatt, which is, so it didn't take too much time. That is the system that we were using. Avedro provided us with that machine because we designed it together with them. And then we compared customized cross-linking with standard cross-linking. You see, pretty much everything is non-significantly different. The standard crossing was a little bit thinner, but significantly thinner, but the rest is pretty much, and those guys were a little bit younger than the customized cross-linking group, but in essence, they were pretty much the same. And that's a typical case, 1 year after cross-linking, the case I showed you, that is the pattern. That is 1 year after, and this is the difference map. And if you look at the difference map carefully, you see 2 effects. One is flattening over the cone, where we did the most. But also you see a steepening at the opposite, which is, of course, beneficial. That's why we introduced the so-called regularization index at that time, because this is much more, that tells you much more optically than only the flattening. You also see in the OCT that kind of demarcation line that goes very deep, but is localized primarily over the area. 3 years later now, those patients were coming in for the 3-year follow-up this year, and we could see that no, that's not, oh yes, that's 3 years later, you can see that the epithelial healing is faster in the customized cross-linking, but that is not such a big stuff. But the flattening is significantly better in customized compared to standard cross-linking, and also the regularization index. Visual acuity was unaffected. Another case of this series, 1 year, 3-year post-op, that was the treatment pattern, and you see there's a significant flattening in the order of blue, whoops, it's not shown here, in the order of 5 or 6 diopters of flattening. Let's see this one, 1 year, 3 years post, preoperative. You see, that's not a bad keratoconus, but it started to become one. It was a progressive keratoconus, and you can see that you can reverse it. But there, again, we have that thing that we saw before. At 1 year, it was flat. At 3 years, it was more flat. Hopefully, it doesn't continue like that. But I'm not sure. That's how nature is, and we have to have this in mind. Now, the real interesting thing is seen here. In the standard cross-linking, you have 58%, so 2/3 of the patients are just stable. They have not changed at all, and it's only 11% that have a flattening of more than 3 diopters. 20% more than 2 diopters. In the customized cross-linking, on certain things are totally different. 2/3 of the patient have a flattening of more than 1 diopter. 56, nearly 2/3, so 60%, have still a flattening of more than 2, it's not 2, it's more than 2 diopters. And here, still 40% have a flattening of more than 3 diopters. Look at that. What the hell is that? 71, totally screwed up cornea, thinning somewhere there. You see a border. And if you go, wait a second, if you go for the OCT, you can easily see that there's much, Absolutely right. Hey, when I gave that talk at the American Academy, nobody said Terrien. They call it Terrien. Yeah. You are? You see? So it's a morbus terrien. That is a French ophthalmologist. 130 years ago, he described the kind of thinning of the superior cornea. And so far, we have no therapy for terrien. Just you look at it and then you do a keratoplasty, but it doesn't work. It's rejected because it's so close to the limbus. We had no valid therapy until now. But then the customized cross-linking came in. Now we do the cross-linking over there. We don't need to treat the center. We need only that area where it's thinning. That's customized cross-linking. See what happens? 1 year later, the patient's back at 2030. He can work with glasses again. He's an illustrator of medical books, by the way, and he works again. So in essence, I got art from him also. So in essence, see the difference. The localized, customized cross-linking helps a lot. This is a little bit more of a puzzle now. Damn, what is that, a kind of a topography? That's totally wrong. It's flat in the center and steep in the periphery. Is that an inverse keratoconus? Hmm?
After keratoplasty?
You shut down now. Of course it is. If you look at the anterior float and posterior float, you see it's bulging out in the mid-periphery and the center is flat. And you see what it is. That was a nice transplant 20 years ago. It's a little bit thick, so endothelium has not survived too well. But you can see the keratoconus continued outside in the host, moving forward, creating steepening outside, steeper because it moved forward, steepening outside, and leaving the flat area in. So where shall we do the cross-linking? Of course, somewhere around. See, that's what we did. So customized cross-linking can do also only the mid-periphery, leaving the host, leaving the donor alone, and just doing the localized weakening, converting the localized weakening of the cornea to be a strong part of the cornea back again. And we do have a few more of these applications. And if you have a strange case where you think a localized cross-linking might help, send him over to Zurich. Most probably I will, if it's interesting enough, I will treat him for free. If it's not interesting, I do not. Customized cross-linking appears to be more effective. It is certainly more effective. You get flattening of 5, 6 diopters on a routine basis. Customized cross-linking to be safer, I'm not sure about that, whether it takes 3 days or 2.5 days to healing the cornea. I think it doesn't matter that much. The regularization process continues again for years. You have to have this in mind. And new patterns will be designed for special applications. And if you help me, I would be more than happy to cite you. Thank you very much indeed.